Thank you very much, Mary, for those kind words. Thank you to the organisers for inviting me. I'm very happy to be here. It's a great honour to be speaking to you all. Hopefully, I can explain a little bit about how we decide about treatments or not treatments in children who've got advanced cancer, and hopefully generate lots of questions. Michael Capper, who's one of my colleagues, often says that the person who learns the most about or when a talk is being given is the person who prepares it, and I think that's really quite true. I think I went through about 3 versions of what I was going to say. You know, you could take the opinion that in the good old days there was no internet, oncologists were left alone by you lot, and we could do what we liked. It's not true and it's not fair. I think the internet is a boon, but it's a challenge. And if you know how to use it properly, you can direct care, you can avail of the best treatments, you can look up colleagues across the world who maybe have encountered a situation. And if it's done badly, you get into all sorts of trouble and difficulties. And I'm going to show a little bit about that and how that, I think, makes the journey bumpier. The other version I was thinking about was the need to justify giving chemotherapy in the setting of advanced cancer, and I don't think we need to do that anymore. I think there's enough data and literature out there. I was actually quite surprised how much there is about the benefits of the right treatments given in the advanced setting. It's not always appropriate, it's not always done very well, but there are certainly situations where there can be medical benefits, psychological benefits, and even family benefits. So that's sort of the context of what I'd like to talk about. I don't have any real disclosures other than to say that I'm not going to talk about much in the way of scientific data, and this talk represents my perspective. These are my opinions, and I decided to try and do quite a personal approach of maybe the factors that influence me in how I make decisions and recommendations and work with the wider team. And so really what I want to do is to show you the landscape of the factors. And I want to start off with a story that you're probably fairly familiar with the situation. Julie is a 4-year-old girl. She's from Athlone. She lives at home with her mum and dad and her brother. Her mum is pregnant, and her dad is a soldier based in the barracks in Athlone. Mum does accounts. Dad is a farmer. Her dad is a farmer, and they're very happy. She then develops a fever for a few days. She's quite irritable, and her parents notice that she's developing a lot of bruising. GP diagnoses her with a viral illness, and 2 days later she's worse. Her parents become more worried. She becomes pale, lethargic, won't weight bear, and her tummy is swollen, and she's sore. She's referred to Ballinasloe. In the hospital, the junior doctor notices that she's very pale. She's bruising around her eyes. She's a palpable tummy mass, and she's very distressed by hip pain. Julie is given pain relief, IV fluids. She has blood taken, a urine test, and an ultrasound of her tummy. And 2 hours after arriving in the hospital, 5 hours having been at a party and being perfectly well, the pediatrician tells her parents that she has a life-threatening metastatic cancer called neuroblastoma, and she needs to be sent to Crumlin. This happens about 5 times a year for neuroblastoma to us. They meet an oncologist. The oncologist tells them that, yes, there have been great advances in treating neuroblastoma. 10, 20 years ago, survival rates were 20%. Now they're about 50%, but the treatment is hard. We've lots of data from America and Europe on the combination of bone marrow transplant, immunotherapy, induction chemotherapy, radiation, but there is a chance that we can cure your daughter. We participate in clinical trials because they're the only way we're going to make progress in curing children, but also they often provide treatments that we can't access otherwise. but it's a very complicated process. So their daughter has just been diagnosed with cancer, and I talk to them about this, which is the high-risk neuroblastoma treatment protocol. It is extremely complicated, and I think even pediatricians in Crumlin looking at this will go, I don't know what you're talking about. I am obliged to get informed consent. So I have to explain it to them in a way that makes sense to them, that they can give me a rational decision. And I'm saying, and we need to start the treatment because she's getting worse. So it's a very, very emotionally challenging situation. In this situation, it's pretty clear-cut. If she doesn't get treatment, she's going to die. If she gets the treatment, she should be feeling better. At least she should be feeling better within about a week or 10 days. And then we build the trust, we build the relationship, we talk to them, they're in hospital, and we hope that as we go along, they can learn to ask the right questions, because the only way, really, I think, that you can confidently say that parents or families understand what you're telling them is if they ask you a question. It's a little bit like the fine slide that Dr. Wolf showed you. They will do anything to save their child. And we have to be able to tell them in the right way and the right context and provide the information to them at this really, really difficult time. So Julia starts the treatment. So I'm going to digress a little bit. So the landscape, I was looking for a picture of a countryside landscape to try and think about this, and I thought this was quite good. There's a road, it's a journey, there are mountains up ahead, it's rocky, the sky is a little bit ominous, but it's a little bit beautiful, maybe signifying the kids. That's one way of looking at it. I think the journey is a little bit more like this. There are lots of blockages, lots of people trying to sell you things, you can't get what you want, you don't know where you're trying to go. And hopefully we can help people through this. Some more, a little bit about the context and the landscape. We see about 160, 70, 80 children a year in Crumlin with cancer. Sorry, this doesn't project really well, but this is cancer incidence statistics from for the country. On the left, are the adult statistics. And as adults, we have a 1 in 3 risk of developing cancer in our lifetime, and kids have a 1 in 500 risk of developing cancer in their lifetime. So that corresponds to 40,000 adults a year in Ireland with cancer versus 200. I'll come back to that. About 20 to 30 children a year die from cancer, which is about 20%. Which is a lot better than it used to be, but it's certainly not as good as it needs to be. I think that it's important to acknowledge the differences between pediatric oncology and adult oncology, especially for an audience who has to look after both, and I think might struggle a little bit in terms of knowing what's going on in pediatric heads. A colleague said to me, you know, there's this old adage, children aren't just small adults, but he went, they're a different species. And they really are. And the whole process of looking after children, I think, is a completely different ballgame and territory. And that's why there are specific people who do that. Children respond very differently to chemotherapy. They tolerate the treatment much better. So we can give chemotherapy to kids that an adult would never tolerate. They would never allow themselves to be admitted for 80 days for chemotherapy because they wouldn't be able to, because they have family, they have children, they have a job. Whereas children, if they're with their parents, will pretty much let you do anything. I see about 40 new kids a year. An adult oncologist sees 500 to 800. And I think that's a real part of the challenge of the transfer from pediatric, not the transfer, but the integration, I think was a great word, of palliative care and supportive care in pediatric oncology. Because we have a relationship with our patients that adult oncologists can't, it just doesn't happen. Because I see 20 times less patients. So I have a relationship, the people in Crumlin have a relationship that is based on time and and going through the journey almost. Whereas adult oncology in Ireland, they're putting their fingers in the dikes, trying to keep up with what's going. And I think that's part of the challenge of integrating children in the palliative care setting in the scenario where the treating team are so involved and divested. And I think that is a source of challenge for parents to be able to move on. The other big issue is that the patient is not the person who's making the decisions in the majority of cases. So you have an advocate, you have a guardian, a parent usually, who's making these decisions. And it's quite a different scenario when you're the person, when you're making a decision for somebody else. So how much is what you're being told influence what you would want for yourself versus what you would want for somebody else who is your child or your responsible person? So a little bit more, the landscape. Parents with children, I think, feel guilty. I think they feel distressed. I think they feel anger, fear, anxiety, sadness. And these are things that are a challenge. We have to address them. I would balance that with the strength, courage, wisdom, fight, adaptability, and love that hopefully helps to manage these other things. These other possibly negative feelings they exist, they're there, we have to deal with them. But it's remarkable, and you see it time and again, that the positive aspects help to control the less beneficial aspects or personality scenarios. The patient, of course, is key to the whole process, and it's very different if it's a child, if it's a baby, if it's a preteen. I think preteens and teens are they're different species as well, and I think how we make decisions with each of these age group patients is very different, and how much you include them, how much you should include them. Possibly we're not as good at including them as we want to. I think we're very familiar with the scenario where the parents don't want the child to know anything because they want to protect them. The child doesn't want the parents to know anything because they want to protect them. And so we have to negotiate that, and there are some families who want their child to know everything, to be the center of every decision, and there are some who absolutely do not. I think they're both a little bit challenging, but in principle we want the children to understand a little bit of what we're doing and why. Although I said they'll allow us to do everything, that doesn't mean that we shouldn't try to explain why. So the oncologist, and so this is me speaking a little bit from a personal point of view. We're physicians, we're pediatricians. Hopefully we have some wisdom and compassion. Hopefully, I think possibly the most important thing is that we can communicate. We have some skill. I think parents want us to have diagnostic skills, and experience is really important. But then there are the more personal things that have nothing to do with medical school. Your faith, I believe in God. Does that influence the decisions I make? It probably does. My cultural background, I come from a pretty conservative country that's struggling with the challenges of the 21st century and amendments and differences in medical care and how we go about things. Am I a parent? I'm a parent. I think that influences things to a certain degree. I'm not sure it influences my decisions, but I think often parents come to us and at the very beginning, do you have kids? And I think if you say yes, they nod and go, okay, so you have a tiny degree of understanding of what I feel. I don't really. If I said to them, I have no idea. I can try to imagine, but I don't really know. But I know the love. I don't mean to say that if you don't have kids that you don't understand, but I think it helps parents a little bit. Am I an isolated practitioner? Do I work in a team with other people? Do I have help and support? Am I happy? Do I give out stink about the traffic in the morning, or do I know that that's a minor issue and there are much bigger problems in life? And I think these are all things that influence how we make decisions. So in the context of outcomes which aren't as good as we want them to be, we know that there is a need for new therapies. We know that we want to be able to treat children if the first line of treatment isn't working. We would like to be able to stop children suffering a relapse, and if we were able to cure enough children, we would like to decrease the toxicity that they suffer. So that's a little bit about the landscape. I'm going to go a little bit off into biology because Maeve asked me to explain the MIBs and the MABs of modern treatments. So don't worry, it's just to show you and to explain a little bit. We understand a lot more about cancer and how it works. We understand how it causes problems. We don't exactly understand why one person develops a problem and another doesn't, but we're beginning to understand the cell, and by understanding the pathways that drive cancer, we're starting to be able to target the specific paths in the cancer cell that cause the cancer. This is just to show you that each one of these little colors represents a potential target for therapy in a cancer cell. It's extraordinary. I guess the benefit of so many people suffering cancer is that there's a lot of research. Pharma companies aren't going to spend money developing drugs if they don't think they're going to make money. So pretty much everybody or every company is spending millions and millions of dollars and euro trying to develop new targets. One of the really sexy new treatments are checkpoint inhibitors, and these are medicines that are being used. Probably you've come across some people with advanced melanoma, bowel cancer, so lots of things. Are the arguments in the news last year about the government not providing pembrolizumab and then deciding to do it, and this is an explosion in therapy and knowledge, but it's a little bit complicated, so I thought I would show you a video.
Hello and welcome to Dana-Farber Science Illustrated. Today we're going to be taking a closer look at how scientists use drug agents to help our immune system discover cancerous cells. Our bodies are made up of trillions of cells which work together to keep us healthy. One group of white blood cells, known as T cells, act as our own personal guides. They patrol our bodies relentlessly for signs of infection or other diseases and attack them aggressively. While on patrol, T cells use specialized protein receptors on their surface to latch on to cells and fully inspect them for signs that they may be cancerous. Once they've made a confirmation, T cells summon an attack on diseased cells. However, sometimes the T cells aren't able to recognize the bad cancer cells and they never attack. Scientists have found that many cancer cells carry proteins that act like masks and allow them to blend in with healthy cells. One protein in particular that cancer cells use for this deception is called PD-L1. When T cells use their PD-1 protein to latch onto cancer cells' PD-L1 protein, they're fooled into thinking that cancerous cells are actually healthy ones. They then leave the cancer cells alone and allow them to go on multiplying in the body. Scientists realized that if they could find a way to block PD-L1 on cancer cells, then the T cells could unleash an attack on them. This discovery led to the development of drugs made from natural human antibodies that block PD-1, PD-L1 protein interaction. The T cells are then able to recognize the cancer cells and begin their attack. Thank you for joining us on this brief look at the exciting field of immunotherapy. For more information, visit discovercarebelieve.org. And until next time, this has been Dana-Farber Science Illustrated.
Okay, so the bald guy with the glasses is obviously me. and I'm very smart. But no, so I just wanted to show a little bit about some of how these things work. I mean, that medicine is probably going to cost 150,000 a year for one patient. So it's not everything, but we're starting to be able to develop new therapies, and hopefully they'll be more effective and less toxic. This is just to show you how many of these targets. This is a neuroblastoma cell and how many potential targets there are in neuroblastoma. Of course, this is 16 years ago, Gleevec, which is used in GIST and CML and some other cancers, was on the front of time, and we're going to cure cancer because we've got the magic bullets. 16 years later, we're still struggling, but hopefully we're making some progress. In the interest of time, I'm just going to move a little bit forward. This is a PET scan of a person. On the left, in the bottom left, you can see they have a big tumor. The yellow signifies very active tumor on a PET scan. And on the right, you can see the shadow or the outline of where that yellowness used to be. And these are the types of responses that we're seeing in some people with these types of medicines. The problem is maintaining the durability, that they last long enough, is an issue. And so we know as oncologists, they're not the be-all and end-all, but they're definitely better than what we had before. And we just have to figure out a way of using these medicines with the old-fashioned medicines in some form of combination that will help. In Crumlin, we're part of a relatively new consortium of centres across Europe that work on developing pediatric trials. These are early phase trials, so testing new drugs in children with cancer. This is a list of the trials that are open at the minute, so a lot of phase 1 and phase 2 trials. These are completed trials, so again, not a number. And this is just to show, in terms of neuroblastoma, CAR T-cell therapy, which is the current newest sexy thing on the block. There are 6 worldwide trials looking at CAR T-cell therapy in neuroblastoma, so a lot of research. Just to show, this is data from America for their recent neuroblastoma trial, and the curve is improving. So the survival at 3 years is 60–70%. So we are making some progress. And this is to show, this is the NCCP's oral chemotherapy list. It's only a little bit of it, but there are 31 medicines licensed for use in Ireland as oral chemotherapy. The MIBs and the MABs, not necessarily the MABs, but the MIBs, and all for relapsed refractory disease, essentially. So I'm sure a lot of you have come across these medicines. We need to be able to use them better, because when you look at a trial of one of these agents in adults, success in for these agents is to extend the progression-free survival, so the amount of time it takes for the disease to start growing again, by 3 or 4 months. And that's a success. And a drug company will be able to market and license that drug and make a fortune off a 3 or 4 month benefit. Whereas in pediatric oncology, 3 or 4 months is meaningless. In the grand scheme of things, we're looking for 80 years. So it's a challenge for us. So coming back to Julia. So Julia, I guess a lot of the time there are 3 sort of scenarios, well, there are 4. One, things work out and everything is great, but often the disease comes back, and in a situation of children being very well with recurrent disease, and that's a particular challenge. Should we treat? Should we wait? If we give treatment, will it delay things? It might, but it'll certainly make them unwell. Potentially it'll involve hospital visits, potentially blood tests. It might involve a central line. It's a little bit easier. Well, maybe there are less options when the children are unwell. If they're unwell, we obviously have to relieve their symptoms and the burden of what they're experiencing, but the decision is they're unwell because the disease is quite aggressive and things probably will happen quite quickly, and so it's a treat, not treat type decision, as opposed to a wait and we'll see how it goes, which I think time is always great. Time allows people to adapt and to cope and to think of questions, and if we have time, we always prefer that parents have time to go away, think about things and come back to us even after a week or 2. because they've been able to hopefully rationally digest the information as opposed to emotionally giving you an answer on the day because we need to do something now. So in that type of situation, we talk about the options which I've mentioned, IV chemotherapy or some form of oral medicine. Not all relapse diseases have a poor outlook. Standard leukemia, the outcomes for standard leukemia are better than for high-risk neuroblastoma, for example. So it's not always the case that relapse is ultimately going to end up in a very a poor outcome. The aims of what we're thinking in our head, why would you give treatment? So you would like to potentially shrink the tumor or the disease, slow it down, prevent further growth. Potentially, could you cure the child? Are you treating the parents? And that's a challenge sometimes that parents really struggle to be able to accept that we can't do anything else, and should we, just give it and we'll see. And it is not a good reason, but we have to just negotiate and figure out a way that whatever we do for the child is at the center of the decision. And I guess something that's really important is that we reevaluate what we're doing regularly, that we don't just consign the child to 6 months of therapy or a year. We review what we're doing at regular intervals and what are the goals of what we're doing. So Dr. Wolf showed this again, and I'm not going to go through it, but it's obviously quite different in basis to the idea of personalized medicine. And personalized medicine is a challenge for us. It's a challenge for us in this country. It's a challenge around the world. You're probably familiar with the concept of everybody has a unique personal genetic makeup. The tumors are different. Can we treat people according to their specific disease and targets? There are commercial companies across the world who will take tumor samples. You hear them on the radio the whole time. They're going to tell you your genome and who you're related to, and they'll find your relatives in Australia. But they can take a tumor, they can look at the genes, and they can give an output like this where they can tell you there is a gene in your tumor, it's active, we could target it. Parents in a situation where they're being told there is very little that we can do will consider anything. Of course they will. They're advocating for their child. If somebody tells them, yeah, there's a chance we can do something positive for you, of course they're going to entertain that. So this is a website from the US, and I don't know if you can see it, but in the bottom left-hand corner there's a button that you click that says Find Hope Here. You won't be able to read this, but this is Sloan Kettering. It's a very big institution, very famous, does a lot of great research. But in their neuroblastoma section, they promise that they are going to be able to, after suffering a relapse, our team will devote itself to shaping a treatment plan that meets your child's unique needs. If I were a parent with a child who had relapsed neuroblastoma and I read that, I'd think, okay, well, you can probably cure my child because you are going to be able to focus. Or at least I would be hoping that's what you're going to tell me. Interestingly, this is one last one. This is another institution where a trial is being run that we in the community have significant concerns about the ability of this trial to prove what it's trying to prove. But they're having statements like it's great for the world to know children with neuroblastoma have another option. The trial is rubbish. There is no way that they're going to be able to prove what they try to prove because they're not, anyway, you just have to take my word for it. And we struggle with this. I took this from Dana Faber, and we've had some very nice interactions. Parents will often ask us for a second opinion, and we're very happy to be able to provide that, and I guess we do it in two ways. There are people we know and we can refer to, or we can support you if you want to go and find somebody else, as is your right. The Dana Faber approach, they have a website and you click through it, and at the bottom it says, at present it is very difficult to cure relapsed high-risk neuroblastoma. For some patients, it can be managed as a chronic disease, which is a very holistic, reasonable, sensible statement to put on your website. But if I was a parent, I'd read that and I'd go, doesn't sound like they're going to help me very much. I think I'm going to go to Michigan. So I'm running out of time. So just quickly, the challenges for me, when should we refer to palliative and home care teams? I think we're very good at mentioning it, and I think we're pretty good. We're not the laggards, I hope. I think we mention it, but I think because of the relationship we have with our parents, I think families often are very reluctant to let go. And what's hard or a challenge is to try and persuade them that it's not letting go. It's just a change of situation. There are new people. And I know that there are probably people in this audience who struggle with the timing of referrals and how it happens. But I promise you, it's not because we're leaving it to the last minute on purpose. It's because we're genuinely trying to help the families to do it when they're ready. Now, I acknowledge that doesn't always happen at an optimal time, but it's challenging. Who is making the decision? If it's the parents, is it the child, is it the physician? Is the child making decisions because they want to please their parent? And why is the decision being made to either give treatment or not give treatment? And if it's treatment, can we do it in a way that is child-centric, that is not unreasonable and out to lunch, that we actually can achieve the goals we want to achieve? And ultimately that we review those goals. So I have an acknowledgement, and I think, if we get it right, it's due to the whole team in Crumlin, because it is a team effort. If we get it wrong, it's probably my fault. And I hope that you can understand a little bit of the landscape and the territory of how these decisions get made and how we help parents, hopefully, to be able to make the right decision at the right time for their child. It's a grey landscape. It's not black or white. There are no one-size-fits-all, as I'm sure you all know. And we hope that we can adapt to the individual situation, and we hope we don't wreck your heads too much. So I'm happy to take any questions.